Which energy and which morcellator? Which energy? There is low power versus high power holmium, TFL inoculation of the prostate, and bipolar inoculation of the prostate. HOLIP was typically performed using high power holmium YAG laser, range from 80 to 100 watt. But can we cut the initial cost? The first randomized trial testing the low power HOLIP against the standard high power HOLIP was done in our center. About 60 patients in each arm with laser setting, 2 joule in each arm, but the frequency differ in low power only, 25 hertz in low power, and in high power, 50 hertz. The procedure were done by 2 surgeons who passed the learning curve of HOLIP. Surgeon A with 250 procedures prior to the study, and Surgeon B 30 procedures prior to the study. And the primary endpoint was the inoculation efficiency, the resected prostate weight divided on the inoculation time. The overall inoculation efficiency showed no significant difference between low power and high power, even with Surgeon A and Surgeon B. 2 weeks post-operative dysuria was comparable on both groups on visual analog scores of pain. There was significant comparable improvement in IPSS score, in quality of life, Qmax, PVR in both groups at 1, 4, and 12 months. BSA reduction was 89% in low power group versus 81% in high power group. And there were no significant changes regarding sexual function in both groups. So low power HOLIP was shown to be non-inferior or comparable to high power HOLIP in terms of all efficiency parameters, regardless level of surgeon experience. Regarding TFL laser inoculation of the prostate, a randomized trial on TFL versus holmium inoculation of the prostate on 150 patients, and the follow-up was after 3 months, and the preoperative prostate volume was 80 cc only. Inoculation time and efficiency show significant difference in favor to HOLIP group, but other outcomes were comparable. So the inoculation time was 27 in HOLIP group and 36 in TFL group. So the TFL is not inferior to HOLIP in terms of functional outcome with a comparable safety profile. But also we have to remember that the size of the prostate preoperatively was only 80 cc. The meta-analysis consists of 10 randomized controlled trial comparing HOLIP versus bipolar inoculation of the prostate on 1,157 patients. The conclusion of this meta-analysis states that HOLIP showed some advantage in less hemoglobin drop and less possibility of blood transfusion, shorter hospital stay, and shorter catheterization time. So HOLIP is recommended in patients with high bleeding risk and prostate of any size. The larger the volume of the prostate, the easier it is to bleed. So HOLIP is recommended in this case. Comparable functional outcome, IPSS score, Qmax, sexual function, and continence. Most of these studies, the preoperative mean prostate size not exceeding 100 cc. Only 2 studies, the mean size is about 125 cc. So we can say bipolar inoculation is safe and effective. It's more accessible and cheaper. And again, all the studies is about the size is about 100 cc only. Which morcellator? Many difficulties could be encountered during morcellation. such as impaired visibility with minor bleeding, malfunction of blades. Also, the morcellation process might come after long procedure of enucleation. So we are looking for safe, rapid, and effective morcellator toward optimizing prostate tissue retrieval following HOLIB assessment of two morcellator and review literature. This study was in our center, comparing two popular tissue morcellator, Pirana with oscillatory movement, and VersaCut with guillotine movement. All parameters showed advantage of Pirana with higher tissue retrieval rate, about 60.2 versus in VersaCut 2.1. The number of procedures done per blade, 22 versus 18, and the total prostate tissue retrieval was higher in Pirana. So it's not only effective only, but also more safe. Regarding the safety, less bleeding and bladder injury in oscillating blade morcellator rather than the VersaCut type. And now, the non-morcellation approaches. The luxury of having morcellator is not always present in all hospitals. These are our experience in prostate tissue retrieval for non-morcellation approaches. For years, we don't have only one morcellator, it was VersaCut, so this is our experience in non-morcellation approaches. Mini laparotomy approach, in the same lysotomy position, a transverse 3 centimeter only in the lower abdominal incision, followed by transverse incision of the anterior bladder wall, then extraction of the adenoma, and after that, watertight closure of the bladder wall. In the presence of concomitant pathology like large vesical stones or bladder diverticulum, after endoscopic enucleation, the patient is positioned in supine position, a classic midline subumbilical extraperitoneal incision, classic cystostomy, extraction of the adenoma and vesical stone, then bladder diverticulectomy. If the adenoma could be resected within a reasonable time, we can do mushroom technique, in which the adenoma is partially enucleated, leaving it attached to the bladder neck from 3 to 5 o'clock and from 7 to 9 o'clock on the right side and on the left loop. Then we start to resect. Unfortunately, in one case, during doing mushroom technique, the adenoma was completely detached and pushed completely inside the bladder. The resection of the freely detached adenoma inside the bladder is relatively difficult and associated with risk of bladder injury. So, a suprapubic 5 millimeter transvesical laparoscopic port was inserted here, and then insertion of tissue grasper to hold the adenoma during resection of the adenoma. Thank you.
Thank you very much, Dr. Ahmed. So, what do you think about putting a suprapubic 5 millimeter port and resecting the adenoma in situ? Is it a piece of cake, or it would be difficult as well? So, would you advise our colleagues to do it as a routine?
No.
Never. So, it's always difficult because you have